To same. Okay. We are going to start this session on master stroke to deal with the challenges, a video and case-based study. I have with me Dr. Subhash Joshi from Nagpur, Dr. Mahipal Sajdev, myself Dr. Chaudhary, Dr. Harbans Lal, Dr. Ashok Shroff, and Dr. Chitra Ramamurthy. Request Dr. Harbans and Dr. Shroff to come on the dais. Dr. Rajesh Joshi, the course study based will going to show two minutes video on a different situation of the cataract surgery and one interesting case to discuss about this. Dr. Rajesh, are you ready? It
will take hardly 30 seconds for me.
Yeah. Good morning, you are the guest. Okay, please join us. Along this, we have our guest speaker, Dr. Madhuban Raman Chaudhary. He will be going to speak on my way of managing astigmatism during cataract surgery. Yes, Rajesh.
Yes, I think
Video.
please help me to project my slides. Yeah. Good morning, everyone. At the outset, I thank Dr. Raju Chaudhary for including me in his IC. Last year also, we had IC on similar type of challenging situations in cataract surgery. Now, I want to show you this situation wherein one never wants to fall at the outset of the surgery. I will project this video. This video is edited one and fast forwarded. Now, cataract is fairly simple and it looks to be easy with initial incisions of side port and main incision. When I introduced my utrata, there was little bit movement of the nucleus, but I thought it happens sometimes if the zonules are weak. But I saw some vitreous coming out through the section at the outset only. So I call this as an unwanted guest, which nobody wants to face at the outset. So my initial reaction was to cut with the tissue, of course, and I have sutured that section. And as the zonules were weak, I stabilized zonules on that side by implanting endocapsular ring of around 12.5 millimeter size. So it went well into the bag. I shifted upwards and made superior clear corneal incision for emulsification of nucleus. The nucleus was around grade 3, but I could chop and remove the nucleus instilled viscoelastic after the stabilization of the chamber, but sometimes it happens that if you come out, vitreous strands also try to come out. So whenever you are forming the anterior chamber or coming out, you place the viscoelastic and then come out. I stabilized the lens, but the lens wasn't well fixed into the bag. So few fibers were there. So I constricted the pupil and stained with the help of tryptophan blue to see the vitreous strands. Vitreous strands were there, so they were cut with the help of anterior vitrectomy. The pupil became fairly round. Small iridectomy was done superiorly, and this was a post-op photograph of the same patient. I think I made few mistakes as I am not well versed with vitrectomy. I used those cutting scissors and swab to cut the vitreous. That should not be done. One should go through the pars plana, do vitrectomy, and then rest of the phaco can be done. But this is the way out for the anterior segment surgeon.
Dr. Shah.
Any comments?
Only thing, whenever you do the manual vitrectomy, that means by scissors, the vitreous has got a tendency to flow towards the incision. And most of the time you will find post-op one tag attached to the side port incision. So you can make another virgin port, put a rounded depositor, and sweep across the incision, and vitreous in the center of the pupil is not a problem.
Yes.
Vitreous attached to the wound is a problem.
Yes, yes.
So just sweep it and keep it in the center.
That
Because
will
during intracapsular days, we used to see the vitreous bulging into the anterior chamber without any problem. So just sweep with the cannula, because you can't visualize it. Just sweep it and make sure that there is nothing, there is no peaking of the pupil. That's
Or you can use, as Harban said, that you can have a separate incision and you can sweep, and along with this, if you use the triamcinolone, we can very well identify the stent also. Because ideal way will be through the pars plana vitrectomy, but sometimes anterior segment surgeon are not so conversant, not used to with this technique.
Yeah.
So that will be the ideal. If you just use the triamcinolone, you can. So now you can go to another, you are presenting another case also.
And secondly, if there is a post-operatively, do not hesitate to tell the patient if you feel there is a gross decentration of the lens, I mean, it's pushing the lens say more than 2 millimeter or so, then actually, and the patient's inflammation is not, go after 2 weeks, when this band is well tight, even if you don't have a vitrectomy cutter, go and put your scissor and just cut it over there, release it over there. So there is nothing wrong in admitting that there was a PCT and we need to set it right.
And sir, I would like to emphasize one thing. When the surgeons, when they get out, I mean, they qualify for the ophthalmology practice, and when they start learning phaco, now it is become essentiality that they must learn pars plana vitrectomy, at least in the anterior part, in the pupillary area. See, this is a part of comprehensive management, and I don't think it should be a very difficult job.
No, it's
But
not
the vitrectomy
difficult.
through pars plana is always very good.
No,
If
no,
you rightly
we,
said,
we all understand what is ideal, but most of the time in many setups and a standalone center in a smaller places with a bulk up cases or 20 cases lying in your list, so it may not be always possible and your staff not trained. So there is an alternative which is not so bad and which can be worked out, but be honest to the patient
I
next
agree,
time.
sir, but
So
complications-
that is the ideal.
But the
There is no denying
complications
about it.
also don't happen every time. Even the complication PCR don't happen every time, no?
Yeah.
But then surgeons, if they are not happening so often, so surgeons are not used to anti-segment or the pars
but they
plana
must learn now.
vitrectomy.
The time has come, they must learn. Thank you.
Yes, I think
You
that's
should
a great
go,
point.
Rajesh,
Yeah.
you have so many.
This one is the second video.
Second.
Small pupil during irrigation aspiration. Sometimes you face this situation, particularly in patients having pseudo-exfoliation or diabetic cataract, or if you have handling during phacoemulsification or nucleus management. So sometimes this happens, and on the second day, you see a lot of cortex behind the nucleus. So again, you have to go back and remove the cortex. This happens sometimes if you don't remove the cortex properly. So I'm going to highlight this situation wherein the pupil went small and what I did to remove the cortex. The pupil at the outset was good, wasn't a problem. So started phacoemulsification of the nucleus. Nucleus wasn't that hard, but the patient was diabetic and the pupil started coming out. I usually make second port at the end of the nucleus management for the cortical aspiration. So trying to aspirate the cortex, this little bit fast forward to compensate for the time. So it's not coming out so easily. Still trying to retract the pupil with the help of second instrument and removing the cortex, but still not possible. The pupil got caught somewhere, and so I thought it's better to dilate the pupil with the help of iris retractor instead of pushing adrenaline into the anterior chamber. It's not dilating, so I thought let us try iris retractor to retract the pupillary margin and then aspirate the cortex. Because here we don't want to lose the battle before you fight it out, because if you lose battle, you may have to call in for vitreous surgeon if there is vitreous come out, or may have to implant endocapsular ring. Suppose if you catch the capsular bag, so make sure that pupil gets retracted, and then go ahead with your irrigation aspiration. But during putting of this iris retractor, make sure that you don't catch the capsular margin, otherwise bag may come with aspiration. And then you can implant the lens.
A nice video on the small pupil. What are the points you think that it is important to take into consideration while putting the hooks when you have already done the rhexis and removed the nucleus?
Yes.
So what is the
of
most
job is done.
important point you should take care?
Yeah, it's a really good question. Most of the job is done. Cortex is the only remaining thing. So you can put adrenaline, or you can put some viscoelastic to cause the mydriasis of the pupil, but sometimes it may not work because of too much of handling going into the anterior chamber, coming out, viscoelastic comes out. Sometimes your incision is also not well sealed, so fluid also tries to come out. So in this situation, I think better to retract with the iris retractor than to lose the battle. While putting the iris retractor, make sure that you don't catch the capsular rhexis margin. If you catch the capsular rhexis margin, your bag may come out, your capsular rhexis may get torn.
Or you can tear that rhexis margin, and so.
So anytime you want to put anything between the capsule, whenever you're putting a sulcus fixated lens, you put on a second eye, you are putting a Malugin ring, you are putting iris reposter, you must put some amount of viscoelastic between the iris and an anterior capsule.
Yes.
That's the key point.
That is the most, the most
and-
important
yeah.
point.
And secondly, you must always have a one Malugin ring, a Bhattacharya pupil expander in your OT, even if the patient is not paying, because now you had to create 4 holes and take so much of a time and putting and taking them out. And because when you put an iris retractor, it stresses the iris too much, because you have got to pull it up to the limbus and causes more pupil distortion than these rings cost. So one ring costing 2,500 rupees, which can be used, so you should keep them.
Rajesh, we move to the fast to the
Yes,
your case presentation, because we have limited time.
Yes, I know that. This presentation, in fact, was done last year also, so I am repeating same thing.
Okay, no problem. Just for discussion, just present
My
the
slides,
case.
please. This is tough shell and hard core. It means that the capsule is tough and the nucleus is very hard. So this is a rare situation. More commonly you see in rural condition where a patient comes late for cataract surgery associated with zonular weakness and hard nucleus. There are difficulties like capsular rhexis staining. You may have to use needle and vanas, micro scissors to cut the capsule, and nucleus management is difficult. You have to decide on table whether to go for phacoemulsification or small incision cataract surgery, and you can expect surprise during any step. So this case 1, 70-year-old male, accurate PR and PR, other eye mature cataract, rest ocular examination was normal. So you can see the fibrotic anterior capsule with a small speck of calcification in the center area. So I thought I will go with main incision and side port, stay in the anterior capsule. But whenever you see some star folds on the anterior capsule, assume that your capsulotomy is going to be difficult. So you may have to use vana scissor or cutting scissors to make the capsulotomy adequate. And during this time, you may sometimes weaken the zonules. So sometimes you may have to stabilize the zonule now that the central capsule is removed.
Can you do slightly fast? We can discuss on that.
So implanted endocapsular ring before emulsification. That missed, in fact, because of fast forward, and emulsification of the nucleus and placing an intraocular lens. Sometimes you may have to cut the entry capsule because the proliferation of the capsular tissue may occur and may cause antericapsular phimosis. This is one situation. So tip is need good micro scissors and forceps for CCC in such cases, CTR implantation, chop technique as stress is less in the zonals. Zepto and femto, how it works, I don't have any experience. These are post-operative follow-up. This one is a second case, 65-year-old female, presented with pain, redness, watering in left eye, other eye pseudophakic. IOP on presentation was high, diagnosed having phacolytic glaucoma. And here comes the case. She has got calcified anterior capsule.
Rajesh, conclude please.
Yes.
Can you conclude?
So here I did bevel down phacoemulsification. In this case, because the nucleus was moving very fast during irrigation aspiration. So bevel down phacoemulsification, that tip facing the nucleus works best in this situation.
Okay, thank you.
Okay, thank you. I will stop here only.
Thank you. Now I invite Dr. Rajiv Chaudhary for his presentation, and he'll be talking to us about the postoperative refractive surprise, role of eye stress, and then videos are about the descent membrane detachment and the PC plaque. Dr. Rajiv Chaudhary.
Thank you, Dr. Shroff. I am going to present one of my first case. It is the old case of descent membrane detachment. And the management, you can see that it is in the lower half 6 o'clock. Old case, long standing, almost 2-3 months. At that time, AIOC was not available, so we are not able to, but that slit lamp picture will give that it is. So by injecting viscoelastic, the descent member slightly fibrous, so and shrink. So we try to do it with the spatula, retract and separate, injecting the viscoelastic, preferably viscod. It give a stretch and pressure, and stretching with the spatula, repositing, thinking that it may work because it was old, and later on we may have to go for keratoplasty or endothelial keratoplasty, so we just have a try to do this. And then removing the viscod with the help of irrigation aspiration and injecting, repeated injection. Repeated injection of air gas, because removal of viscod is also a tough job. If you remove with the IA, you may pull more of the descent membrane. So friends, and you can go for this, that after some 15 days, the descent membrane and cornea is quite clear. So in short, that old descent membrane detachment can be managed if we try and a proper apposition of the. So anything to Harbans you want to add? So we can shift to the another case. Another case is that a thick posterior capsular plaque. Traumatic, and as we want to keep the posterior capsule intact, many times this plaque clamps so easily with the separating. You may need a needle, you may have to use it as a sharp knife. You can see very well, you can dissect this plaque from the posterior capsule, and you may keep your posterior capsule intact if you do a proper dissection without injuring the. And later on, if you feel that this is opacity still is obstructing, you can do the posterior capsulorhexis here. So looking to the posterior capsular plaque, it is not like just like that you directly go to the removing the posterior capsule, you can try to keep a posterior capsule intact as much as possible. Now, interesting, we are going to discuss the cases, role of eye trace in post-operative outcome of the cataract surgery. This is interesting a case with 20-year male BCV 6/9 cataract. There is no other problem. Keratometry 41, 45. We planned for toric intraocular lens. After 15 days, patient came with the decreased vision and dysphotopsia. So on slit lamp also, we find that lens is rotated. And you can see that eye trace finding is a small pupil. There is no aberration. This is the internal aberration from cornea. This is the internal from the lens. This is the aberration from the cornea. And this is the total aberration. But it is indicating the still high refractive error. With the, you can see there is -5 cylinder. Still, now if we increase the pupil diameter, you can see that this lens aberration increases. Means this basically is problem in the lens. With the 4.5 mm, there is total astigmatism at this. And so we try to, that eye trace give a different diagnosis, that it can rotate at 64 degree and it will do 5.26 diopter change in your cylindrical power. And we planned for our rotation. We did the rotation, and post-operatively, you see that aberration at 4 mm is quite less. Astigmatism is reduced. It is on the negative side. That's where the blue line index. And with the 2 mm, that all aberration is gone. So a small pupil or 2 or 3 mm, that aberration is gone. So patient comfortable with good vision. This is another case, 40-year male, monofocal PCIOL. That was the toric IOL. This was the monofocal. Normal vision was 6/6. Patient came with dysphotopsia. As there was no toric plan and the patient vision was, we are surprised to having his as a, what was the reason? We did the eye trace. Eye trace shows the blurred image. The 1 mm, there is no refractive or aberration in the internal or lens range, cornea, total aberration is lens. But as the pupil diameter increases, the aberration increases. You can see that at 4 mm, the total aberration is increased and having 2.25 cylinder. And it was the monofocal lens with the corneal diameter was equal. Eye trace showed that rotated to 1.81, and thinking that there might be some fibrosis and tilting the lens, we tried to rotate this lens, and later on this vision improved. And you can see that total aberration is gone in 1 mm, 2 mm, and 4 mm. Thank you. So, friends, with the eye trace, you can assess your post-operative outcome in where the patients are unsatisfied. Thank you.
Dr.
The second
Chaudhary.
case was non-toric.
That was non-toric. That was monofocal.
What was the reason for?
Probably that capsule fibrosis is tilting that lens and giving the internal astigmatism, the peripheral. So that 1 and 2 mm, there was no aberration. At the 4 mm, there was the aberration. So we thought that, and we on doing there was the fibrosis, and probably that was the foldable lens might be slight tilting the lens and giving the astigmatism.
So you took out of the capsular bag and put into the sulcus?
No. We just separated that hole and rotated the lens. But rotation doesn't mean that it was toric, it was going. Rotation helps in preventing the fibrosis. What was the fibrosis lens at that place? It was remote.
Thank you,
And
Dr. Thank you, Dr. Rajiv Chaudhary. Now I invite Dr. Chitra Ramamurthy for her presentation. She'll be talking about TAS, early diagnosis and management.
1 minute.
Right.
I'm showing the videos and then
Yeah,
I'll,
please.
Yeah. Thank you very much. It's always a pleasure to come to Dr. Rajiv Chaudhary's course. Only thing, because I have a course running downstairs, for the first time I wished that it was not 2 floors up.
You always go.
Always hope. So, anyway, this is just running through some of the, excuse me, just 1 minute. Now, this was a case of a young patient with a traumatic cataract and a very fibrous capsule. Was insistent to have it surgery done on a femtocataract platform. So I initially planned the rhexis to come beyond the presence of the fibrosis. He had some astigmatism, so I had used arcuates to debulk the astigmatism, which it does do to an extent, though not to the exact precise levels. And the femto disruption occurred, and I was really hopeful that it would actually manage to get a good rhexis. Opened up the incisions because it's important to open the arcuates before we start the surgery. Normally I would never inject Trifen Blue, but I have injected Trifen Blue to try to understand how much of the rhexis is in fact being cut. And I was quite pleasantly surprised that although there was a fibrous girdle all through, it was only in this area where the fibrosis was really tough that it was stuck. And I tried valiantly to push with my cystitome, but it's so obvious that I fool around a little more, I would end up with a zonular dialysis and a traumatic cataract at that. You never know, a dialysis may be sitting quietly in a corner. So that's when you realize that our manual instruments, the conventional methods have to be there on the tray so that you could go ahead, and then I cut it curvilinearly along the direction of the rhexis. The cataract looked quite hard, so did gentle hydro to loosen up the nucleus. I thought that was the next ominous task in front of me, but you wouldn't believe it. As I rotated, I realized it was nothing but just a thin disc. Naturally, the patient was young. It was just a complicated cataract which had this brownish hue. So I went on to the flip mode, which is available on the Centurion machine. It does get a little supracapsular, but the whole thing is out in no time. So I realized that this area of fibrosis is there, maybe just do a little PC polishing, and the challenging case was actually, it's going to get done. There was nothing to it. When I found that the PC was getting caught by the aspiration cannula, I went in with the infusion and separated it. But then again, at another point, it got caught. It was quite clear that this was a totally friable capsule. So what next? Do I just hold on to the capsule for what it's worth, or why not iatrogenically create a PCR is what seemed to be makes sense, because this kind of a capsule cannot be a scaffold for an IOL at all. So went ahead and did a good anterior vitrectomy, clearing the vitreous, the debris, clearing the visual area. And of course, the tricot always comes to our rescue to let us know that whether aberrant vitreous has not been cut. So, and it also has an anti-inflammatory role at the end of it if a little bit has filled into the posterior segment, and then enlarge the incision and balloon up the space in front of the rhexis as is being done, and place a 3-piece IOL in the bag. If you can, do an optic capture, and that's the best way to go about it, and this situation got dealt in this manner. Then going on to the, next setting. Very sorry. Oh my God, what am I doing? So, I don't know, I'm going on to the case discussion. There's one other video. आप आ सकते हैं कोई? जल्दी आइए ना, एक दूसरा वीडियो दिखाना है, उसके बाद डिस्कशन हो सकता है।
It's okay.
ये बंद करके, बंद नहीं हो रहा है, ये बंद कर दीजिए इसको, बंद कीजिए। No, he has to. One more to go, तीसरा. Very sorry, doctor, for the delay.
No problem.
Yeah. Now, this is again another situation. Often cataract surgery sometimes becomes like a chessboard game when you wonder whether you're going to be hit with the dwarf or whether the king is going to win. And this was some kind of a similar situation, which started off as a very routine cataract surgery, but then a well-dilated pupil at that created the side ports. One of those last cases where you think you can rule the world, injected viscoelastic, got a nice round rhexis, and I expected that surgery should go optimally. There was no excuse for not dealing well with this kind of a hard cataract, a soft, moderate cataract, a gentle hydro, a multi-quadrant hydro if necessary, but it always makes sense to decompress the bag every now and then, inject viscoelastic to coat the endothelium, and go ahead the usual way, the intraocular pressure that's sitting at 60, the best of machines, and I do my first phaco chop, and feel quite comfortable that it's done, that half the hemi nucleus is cut, and then go on to make one more chop, and I think it's time to eat up the nuclear fragment when I notice a PCR, which has got probably inadvertently created by my phaco chop maneuver. So then what next? So I just go back and inject the viscoadaptate viscoat, which would push the vitreous back. And it's quite clear that the vitreous is not presenting at this moment. So I bring the nuclear fragments up. So if there was mixed with vitreous, this would have been a challenge because that would have tugged on the vitreous at the base. So anyway, things were fairly okay. Again, go back and inject viscoat. And then, yes, I could have used IOL scaffold, but I was just trying to show you that sometimes we think we are quite brave enough. The area of PCR has increased. I just use my second instrument as a scaffold, bring down the phacoparameters, and supracapsularly get done with this. I was lucky here, but then now I would go and do a good vitrectomy as a little bit of vitreous was already presenting, and then go back to remove the cortex, and the ease with which you remove the cortex is actually a clear indication that your vitrectomy has been done well. And once that is done, once the vitreous is clear, there's no debris lying around, now all I have to do is just inject a viscoelastic in front of the sulcus, balloon it up, place a 3-piece IOL, and now this was a nice round rhexis, do an optic capture, and then you have a centered IOL. Yes, you need to go behind the IOL because you really need to clear the vitreous. You can't afford to have any strands. You could even inject tricot to see whether everything is all right and do an optic capture, and you are in the best kind of situation even in these moments. Do I have time for a case discussion?
No,
It's up to you.
just one or two comments. I mean, the first video you showed where you did
Yeah.
the vitrectomy and cut the capsule
Yeah.
while there was no PCR.
Yeah.
So whether, using CTR will tighten the capsule? I mean, put
No,
on a CTR because
yes,
the posterior
CTR
capsule
would
was
tighten in
floppy.
subluxated cataract, but this was
Yeah, I know, I understand
it was
because
so
the capsule
friable.
was floppy.
Yeah,
I have seen many a floppy capsule,
Yeah,
we put
yeah,
on a CTR, it becomes
yeah,
tight.
yeah.
So you can
So I
use
don't
the-
think the CTR and an IOL, the posterior capsule could have held all that. It would have all gone into the vitreous. So this is one extreme situation wherein that was the only
No,
solution.
not in this case, previous case. In the first case where you did, the capsule was coming into your phaco probe.
That is what. The posterior capsule was so friable. It was just folding up. It wasn't it was not that
No,
kind
no,
of a
the
capsule of a
capsule was not
subluxated.
friable. If it was friable, it was a broken when it was caught. Capsule was lax. And the laxity can be tightened by the CTR. So
True.
that was the point.
Yeah.
And second point was, whenever you put tricot, I usually prefer to put on a tricot after placing the IUL so that it doesn't go into the vitreous cavity. In this case, like a lot of the tricot gone into the vitreous cavity.
Yes.
So I put the IUL and it was a planned vitrectomy. So even if required, can be done through the pars plana.
It was not banned, yes.
Okay, thank
Thank
you,
you.
Dr. Chitra. I think Dr. Mahipal has to also rush through, so.
Yeah, so
let-
it was a nice case discussion. I'll keep it for the next term.
Oh, okay, thank you.
Thank you very much for allowing me to talk.
Oh,
Thank you.
Okay, thank you.
Thank you, ma'am. I invite Dr. Mahipal Saddev for his presentation.
Okay. Well, I'll be showing you certain situations which have been given to me. This is called as the IUL scaffold. So this is a femto procedure that we are doing. And you can see this is a polar cataract. It can be easily visualized. So this is the fractionation of the nucleus that is happening. That was the capsulotomy image. Now what you see in this particular case is that we are taking out the nucleus and the posterior capsular rent appears. Now, what do you do in such a situation, which was the specific situation given to me, that there is a hemisection of the nucleus, and because we have not done a great hydrodissection, because it was a polar cataract, it is difficult for us to bring down the hemisection. So I have injected viscoelastic, I have made another opening there, and the sandwich technique is being used, where I am using two hands to actually levitate out the nucleus. Now this is a soft nucleus, and that is why I am doing this technique, because the anterior capsular axis is intact. We will be wanting to put a 3-piece lens. So I have put in a 3-piece lens in the anterior chamber over the iris, and after using the phaco for removing the hemisection, we go back and we do a good vitrectomy, as you can see, and once the vitrectomy has been done, we will remove the viscoelastic and we have dialed the intraocular lens in. So that is what we do in such case. Now, if you have a small pupil, what can you do in a small pupil? Actually, this is the lensex. Even in the catalyst system, you can reduce the capsulotomy up to 3 millimeters. So you can reduce the size of the capsulotomy and go ahead with the fractionation of the nucleus. You can see that's the capsulotomy that is happening, and in the capsulotomy you can see that we are able to finish the good capsulotomy and the nucleotomy. So let us see this. This is another case with the femto that which I am wishing to show you. This is a small pupil. This is a subluxated lens, and you can see that this is the 5.5 millimeters. So you can see that the pupil is somewhere around less than 4. So what we are doing is that we are putting in a Malyugin ring. As you see that the Malyugin ring is being inserted, and once you have the Malyugin ring in place, we will then, there are two methodologies. One is that you leave the viscoelastic, increase the energy of the femto, and go ahead and do the femto procedure. The second is that you can aspirate out the viscoelastic, put a suture, and then take the patient in for the femto procedure. So it is well established that because you are not increasing the pressure of the eye very significantly, you can use a Malyugin ring. You can't use the 4 side ports and use an iris hook, but you can use a Malyugin ring in a femto procedure. And you can see that once the 5.5 now is within part of the Malyugin ring. Okay, so when we started, we were at about 4. Now we are at about 5.5. So this is, now we go to the femto. You can see this is a subluxation. Can you see the iris? It is a subluxated lens, which is very clear. And there was a lot of phacodonosis. It was an angle closure glaucoma with PI done. So now you can see here that we are, once we have the Malyugin ring, we are working on the capsulotomy. We have made it centered. We are going to make the 6 pieces. And you can see that this is the capsulotomy that has been completed. Now you can see that this is the nucleotomy that we are wanting, which is happening. And once the nucleotomy is completed, we can then take the patient to the OR and work with this particular patient. So you see that's the end of the procedure. And just to show you that now you can work and go ahead. And this is my final thing, which is a corneal opacity. Once there is corneal opacity, how would you do a phacoemulsification in such a patient? So the principle is to shut off the microscope light and to use what is known as chandelier's illuminator. So this is a self-retaining chandelier's illuminator which every VR surgeon has. You go in, you switch off the light. As you can see, this is microscope light off. And what is this? That it is a self-sealing wound. It leaves behind both the hands free because it's self-retaining. So now you see this one particular case. This is a corneal opacity, which you can see it comes here, here, here. And if you want to do this, how would you do this? This is trypan blue that we are going to put. And I'll just show you the images that we will get. So this is the chandelier's illumination. The microscope is off. And we are getting the light bypassing the corneal opacity. So the light goes directly, hits the retina, and then comes back, and look at the view. It gives you a fantastic 3D. Can you look at the depth perception that you are getting? It's a fantastic depth perception, and you cannot believe that there is a corneal opacity that is there. So you are actually bypassing the diffraction of the light from the corneal opacity, because it's not the microscope passing through the cornea and then going back to the retina. It is going straight to the retina, and once it is going to the retina, you can see that this is a great outcome that you can have. This is the epinucleus that was removed. This is now you can see the cortex that is being removed, and now you can see that this is the IOL that is being implanted. And look at the beautiful glow that you are getting in this particular case. So friends, I think this is what I wanted to show you. Hemi section left in a polar cataract, you use an IOL scaffold. I wanted to show you as to can you use, this is a blast injury case, and this will also be showing these chandeliers. The second thing is that I wanted to show you was the use of the Malugin ring in small pupil and yet be able to do a good femto procedure. And the third is the concept of chandelier's illumination, which gives you great outcomes in the presence of corneal opacity. Thank you very much for your kind attention. Thank you.
Sir, I have a question for you.
Yeah.
If the cataract is totally mature, fully mature, or maybe hypermature, then do you get the same red reflex on retinal illumination with chandelier?
No, you can't get a chandelier
Total white
illumination, but if it is totally white, it is much better than the other one. But then, if you don't have a corneal opacity and you have a mature cataract, then you don't actually need a chandelier.
With corneal opacity.
Obviously, you have to have something coming back to you.
Yeah.
So if the cataract is totally blocking out the light, you will not be able to get a red
Okay,
glow.
okay.
Yeah. Okay?
Thank you. Now, it's my pleasure to invite the guest speaker, Dr. Mahabur Rahman Chowdhury from Bangladesh. He is a chairperson of Bangladesh Eye Hospital, and he will be talking to us about his way of managing astigmatism during cataract surgery.
Dear audience, it's my pleasure and honor in having the opportunity to share my experience with managing astigmatism during cataract surgery. And as we know, cataract surgery has become a refractive surgery, and it's no longer a vision restoring surgery. It is a refractive surgery. And if we can correct astigmatism by implanting toric lens. And when do they make the decision that we want to put a toric lens? It is during biometry, and specifically while taking the K readings. And if there is a difference in K1 and K2 is steep and the flat axis, that is the time we decide on toric lens. And these are the instruments that we have to measure the Ks, and we take the readings which are in alignment, and we disregard which is an outlier. And these are the machine that we have. And one more important thing that I want to emphasize, that previous glasses and also previous prescriptions also helps us in deciding whether the patient needs toric or not. And definitely we have to use the new generation formula, and Barrett formula is what we should use. And while deciding on toric, counseling with the patient is very important. Not the patient, but also his attendant, because that is, we have to explain the quality of vision that he is going to have, and during cataract surgery. This is an opportunity to have corrected refractive error, which he never had before. So these are the visual images that can help us in explaining to the patient and also to the attendant that we have this quality of vision that can be achieved. So the visual definitely helps. And we also have, since it's a group that we are practicing, a group of 40 together, so we can afford the best quality technique and technology, because by volume, we want to overcome the cost. So we have this digital marking with us, Callisto by Carl Zeiss and Variant by Alcon. And during astigmatism, if it is, this rule of thumb from our institute is that less than 1 diopter, we try to improve or correct partly of that astigmatism by putting an corneal arcuate incision or incision at the steep axis. And rule of the thumb is that anything more than 1 diopter, that is where we use toric lens. And for these days, this is the LRI calculator, where we can decide and put an LRI incision for correcting astigmatism less than 1 diopter. For anything more than 1 diopter, it is toric lens that we use. And this toric calculator definitely helps us. This is the Barrett toric calculator. We put in the datas, and once the data is put, and we can see this is one of the example that this we need to align the axis at 176 degree. And this is another case where it says the lens has to be put in 95 degree. And we do this during implantation. And then comes the marking of the eye. And this can be done manually, and this can be verified in our smartphone by downloading the app, this Toricam. This can be done in slit lamp. And during perioperative, we decide the axis marking, and also the digital marker definitely is going to help us. So this is the marking which my anesthetist does for me. This is the marking he is doing. This is the reference marking, 0 and 180 degree. And from this reference, we can also superimpose on digital marking. And then this is also important. Why am I showing this? I have promised the patient a premium lens. So I asked myself, Dr. Chaudhary, this is something that we have promised the patient, and don't think about the party last night, or don't think about the presentation that you're making in Indore. Be careful, because if we have a round axis, that will keep the lens in center, and we want to see that the rhexis margin covers the optic, because that will reduce the PCO. So making the rhexis is important while using a premium lens. Similarly, we know the nuclear management, but specifically here, whom we have decided to use premium lens, we want to be careful that there's no complication occurs, because if complications do occur, we have to abandon the implantation of toric lens, which we have promised. So we got to be extra careful while we're doing the different steps of phacoemulsification while doing toric. And similarly, I would also say that this cortical cleanup is also important, because if we have clear cortical, we have taken all the cortical matter, the decentration of the lens will be less likely, and also the PCO will be also less likely. So this is one important thing that we have to take into consideration. And IOL implantation, rotation, alignment. These are the important factors while implanting toric lens. So this is the toric lens that we are implanting. This is the regular way. All other lenses, that how we implant the same thing. We implant it, and we are going ahead, and then let this lens go inside, rest in the antechamber, and then we will try to take the viscoelastics out, and at the same time rotate the lens towards its axis mark. And this is what we are going to do. It is simple. We're going to use the same IAT, not any other fancy instrument. This is good enough, and this is possible to rotate the lens with this IAT. And once this is done, you are done. So this is a multifocal toric by Symphony toric lens. That is also possible to implant and to correct toric and also presbyopia. So this is, and we can see the digital marking, that marker, that is also helping. I'm rotating and finally aligning the axis mark with the blue line, which says that this is the axis mark where I need to put the lens. Okay. So initially it should be a little off axis, then rotate it and wait for the final positioning. So this is the thing, and final placement of the IOL. We are rotating, same instrument. I'm now more or less happy, and it is aligned. I'm coming out, and then we can see that this is quite well aligned. I'm happy. So axis confirmation, you can see the blue line coincide with the 3 dots of the axis mark, and this is where we say that, yes, this has been well done. So last, wound closure is important as well, because if we don't close the wound properly, there will be chance of rotation by tilting of the lens. So wound closure is important. At the same time, we know that rotation, it usually happens 1 hour after surgery. So we ask the patient to lie down flat for 1 hour. If he does that, chances of rotation becomes much less. And we know about this. 1 degree, there is 3% loss. In 10 degree, there's 100%, about 30% loss, and 30 degree total loss. So we have to be sure that there is no rotation. And my experience is with 177 patient and total eyes 125, and we check it the next day in the slit lamp to see whether the axis mark and the alignment in the right position. And my result is something like that. So we have about 93% with 6/9, and few patients insisted on remaining myopic. So we did keep myopia in some cases where the visual acuity is 6/12 and 6/18. Having said that, I know that I would say one thing, that toric implantation is very gratifying, very satisfactory, and those who are doing it, I congratulate them. And those who haven't started, I would say this is one surgery, and just do one surgery. It's not different. That you'll get the encouragement, you'll get the confidence, and we can give quality vision to your patient. Thank you for your kind attention. Thank you very much.
Thank you, Dr. Chaudhary. Before Dr. Sharaf does his presentation, just few comments. One is that whenever you are doing a toric implantation, axis is more important than the volume of the toricity. And one should follow the rule of 2 at least. That means the 2 equipment should give the same axis, whether it's an auto-refractor, whether it's a lens star, whether it's a manual keratometer. So at least you should pentacam. So whatever you have, and if you don't have 2 as equipments, if you suppose you have just only a manual keratometer, then 2 observers should get the same type of astigmatism. If you do not even have your another observer at 2 different sittings, maybe after a week you do, and if you are getting the same amount of astigmatism, then you should go ahead. So, but at least depending upon one instrument, it may be very, very difficult. Secondly, whenever you are dealing with a very low astigmatism, then posterior cornea becomes very, very important. So if you are dealing with the less than 1 diopter, and particularly when I use the multifocal toric IOL, I try to correct even less than 1 diopter of astigmatism. So in those cases, the total corneal astigmatism with the pentacam is must, because the posterior corneal surface, if you do not measure, the patient may not have actually 1 diopter, and the axis may also be different. So whenever less than 1, then you definitely need far more advancement. And second, about the surgical tips, what I like to suggest is, these IOLs should not be placed in the eye with the methyl cellulose ever, because methyl cellulose cannot be removed from the capsular bag completely. It keeps the capsular fornices lubricated, and there is a post-op rotation. Either use hydroimplantation or use hyaluronic acid, the Hylon GV, which can be completely removed from the bag. Secondly, the lenses should be pressed from the top. So post-operatively, when you are withdrawing after removing the viscoelastic, your cannula, irrigation cannula, you must inject simultaneously air from the side port so that this lens is pressed down. If you suddenly remove the lens, chamber becomes shallow, lens may get repositioned. We want the lens to be compressed against the posterior capsule. There should be air from the top. And these wounds should not be overinflated. Because if you keep the IOP high, then because the capsular bag is inflated, the lens will rotate. So the IOP when you leave should not be high. It should be in the range of 15, 16. They should not be overinflated. And there should be air on the top and no viscoelastic in the capsular fornices. The chances of lens rotation will be minimal. And I invite, if you want to say something.
Definitely agree with you, but I just wanted to say one thing that to the young ophthalmologists, that this surgery is no different from what monofocal lenses is.
Yeah.
What we have been saying, we don't want to discourage you, so this is the same surgery which we do for monofocal, not much difference. That was the time I want to emphasize.
Actually, there is no way you can go wrong with these lenses. There is no way. Because most of the time, there will be very rarely you will have a more than 10% misplacement of these IULs. And even if there is a 10-degree misplacement of these IULs, maybe 1/3 effect is less. So if your keratometric measurements are correct, the chances of your going wrong are very, very remote. And whenever, another very important point is, when you take a K reading, suppose an auto ref or in a lens, any machine, don't take the average. I ask my assistant to bring all the keratometric readings and see that all the axes are same. One is coming 27, the other is coming 47, 40. That means the patient is suffering from dry eye, you are not getting a correct picture. So if all the reading axis is the same, whether in the auto ref or any other equipment, then it is fine. But if you are getting a different axis and different power, that patient needs a dry eye treatment. So give a low steroids for a week, give the lubricant eye drops. Most of the time, whenever I had to explant the lens, it has been the measurement error than the rotation of the IOL. So if your measurement is correct, you take care of the dry eye, particularly elderly patients with mebonitis, treat these patients for 2 weeks or 1 week, you will get more accurate reading. And another is that, I don't know, I mean, you get your anesthetist marks the point, but these ink dots itself are around 5 to 10 degree thick. So whenever you put on an ink dot, it becomes a reference point for you to find out where the 6 o'clock is. When I mark with the ink, then I make the patient sit like a confrontation test. I ask him to look into my eyes, look straight. Then I mentally analyze whether my 6 o'clock is at the center of the mark, whether my 6 o'clock is the left side of the mark, whether my mark is 6 o'clock is on the right side of the mark. So the mark you put when you're putting your hand, it may not go exactly at a 6 o'clock or 180 wherever you want to place it. But this becomes a reference point for you to analyze where actually the intended mark is. So very important to mark it yourself and make a mental note where this mark is. So if your preoperative assessment is good and the Indian toric IOLs actually work very well, which are available at the cost of the monofocal IOL of the multinational companies, costing you 5,800, 5,000 or something. So even if some of my patients, they don't want to go for expensive IOLs, you don't have to put the multifocal IOLs. You can take the Indian toric IOL and can go ahead and use the toric IOL. These are very, very satisfying. These patients are very, very grateful. Now I invite Dr. Sharaf to give us.
Thank you very much, Dr. Lal, for inviting me. As well as I thank Dr. Rajiv Chowdhury for having me here as his faculty. I would like to share my views and my ideas and my way of managing the extended rhexis and its management. This is a sin. If you have a sin, you are stuck up, you are scared. First of all, you would like to know, understand why does it happen. It can happen if your anterior chamber has become shallow during your rhexis making, either because of the leak or the pressure is already high. Or there may be another important reason that the pressure in the lens may be higher. Or if you are operating on a child, then there is a positive vitreous pressure. So even that can cause extension of rhexis. And once it is done, once you find that the rhexis is about to extend, the regularity is lost, it can be smooth, just going out of the line, then you can it's better to stop and take the subsequent steps to regularize it. That is better. Till then that time you can have a round margin. Like this. See, if you see that, I do not know, I couldn't find what was the reason, but it is about to extend here. See, and this was being done under the anterior chamber without the visco-free phaco. There was nothing wrong in it. Chamber was well maintained, but still it was a little going out of the way. And of course, it could be managed well. And you can see that at the end, this was extended on this side. But still the margin was regular and smooth. It can sustain the pressure. And once, if it is a sharp cut, then it's better you stop it. The moment it's gone out of the way it goes up to the equator, it is better you stop it. And this nick method is very popular. And if you make a nick, but still there are chances that if you, during phaco, any point of time, if the pressure is much more in the anterior chamber, then it can extend into the posterior capsule, leading to the posterior rent, capsular rent, and whatnot. But here, what I do is a hard cataract, right? And it has gone almost up to equator or maybe beyond. So what I do in such cases, that these cataracts I usually take out into the anterior chamber first, and I push it back behind the iris, which is known as the supracapsular phaco. It can, if you don't take enough precaution, it can compromise your endothelium, but you have to be very careful and see that your anterior chamber is maintained properly. Now here, if the cataract is soft or maybe less, then it's easy. If it's a pediatric cataract, again it's easy. You can take the lens matter out only with the irrigation cannula. But here, make sure that you don't press towards the posterior capsule. Your pressure or your making the trench and dividing should be horizontal. And you can see that it's very bad rhexis, but still the posterior capsule is intact. And here, the important point is that you have to put a lens in such a way that the haptics, they don't come out of the bag. And here, what I do usually, I keep the pupil small for 2 to 3 weeks time. So that by that time it gets fibrous, and then there are less chances. So you can see that, and make sure that the rhexis are placed properly, the haptics are placed properly. Still it is in the bag and very good position. So this is possibility with even the extension for rhexis, you can do that. Now every time you don't have a very bad extension, you can see that the rhexis is gone out. I'm making the nick. It's difficult because the capsule is not that healthy, or a hard cataract, and you can see even the rhexis has gone here up to here. So my idea is to show these videos is why stick to this one method, supracapsular cataract. See, you have to see it was about to extend here, but still we have to manage and make sure. Now here, the hydrodissection every time not possible, and should not insist on that you must do very good hydrodissection, push the fluid behind the cataract and make the cataract free. There is nothing wrong if you don't do too much, because that will give a lot of pressure on the posterior capsule, and it can lead to the rent, extension of rent. Here you see the margins are so peripheral, on this side it's not seen, but still you can put the lens in the bag. Again, your putting the lens into the bag has to be very critical, and make sure that the haptics, they don't come out. Now, why this nick method? Why? See, you can see that, see, the rhexis has extended here. Now, if you put a nick, and if you extend the nick this way, right, so ultimately you have a rhexis which has been extended here. Now, if this rhexis has been extended here, upper part, then again you have to be very careful that your maneuveration should be little away from that. And if not, if you go for supracapsular, don't worry about it. But then, see, this step, if you know, this is here, if with only extended rhexis, your angle is acute, narrow. And so wherever the pressure is there, that angle, at the point here, it can extend, go down. if the pressure is too much. But if you put a nick here, then that angle becomes wide. So the pressure is distributed and it can sustain better. What I have seen, even at times, we unwillingly, the pressure is exerted on the chamber, but still it doesn't extend. But the best way is to, if the cataract is hard, the best way is to put do the supracapsular. So this is how you can manage your rhexis once it is extended, if it is sharp. Don't worry about it, put a nick and then proceed further. So thank you very much. Sir?
Yeah,
Thank you, Dr. Shah. I got one question.
Please.
Whether we should increase the bottle height or lower the bottle height in such cases.
You should lower the bottle height.
I've got a contrary view.
You do other way around?
You should increase the bottle height.
Why?
Because I feel whenever the rhexis is extended to the posterior capsule, it is when the chamber collapses, vitreous tries to come forward, and rhexis extends posteriorly because there is a cone. So if the bottle, so all the time you must maintain the chamber depth. That means whenever you are withdrawing your probe, you must inject a viscoelastic from the side port. Your suction power may be less, but bottle height should be, because it is not the fluid which is steering it. It is when the nucleus comes out and the chamber collapses, then this gets extended behind. It is not pressure from the top which takes it back. It is the pressure from behind which takes it back. So I feel that you should not lower the bottle height in these cases. Rather keep it whatever is your normal bottle height. But you can decrease the suction volume. I mean, suction power should be less so that the chamber depth is maintained throughout. And put the viscoelastic before you withdraw.
Sir, means you mean to say that the rent is, the rhexis that is extended in the posterior capsule only when the pressure from behind is more?
Yeah. See, if suppose the rhexis has...
Just want...
suppose the rhexis has got extended into nothing, rhexis will not go behind. Suppose you do no manipulation.
The important
That's not
is
good.
probably is to keep that it to be flat, not to shallow it, not to overinflate.
Yeah.
So if you overinflate also, you have
Yeah.
extension of that
Rhexis,
rhexis also.
yes, absolutely.
If your nucleus is out, if you overinflate, it will stretch more.
Yeah, yeah.
If you make it shallow, it will end. So best is to keep it flat.
Thank you.
So I now invite Dr. Harbans to show two important and one of the case.
क्यों भाई लगा दिया? बंद कर दिया क्या? So this was a patient which has a posterior polar cataract and a hard cataract. And I rarely do block surgery. Most of my surgeries are topical. But I thought this is a nice case for recording, and so I wanted to give a block so that I can have very good presentation ready. And as soon as my assistant gave the block, and she felt a resistance over there, and then she withdrew the needle. But by that time, we can see the subclavian hemorrhage at this side. And because of the very hard cataract, indirect ophthalmoscopy was not very conclusive. But we knew that there something has gone wrong. And this is after we finished off the cataract surgery as routine. And now you can see whether this is a perforation over here, and whether there is another perforation over there, double perforation or not, we are not so sure. And in such a scenario, there is always best to, whenever you have a perforation, please do not wait and do immediate and complete vitrectomy. I had one patient earlier where I had a globe perforation, and I called the vitreous surgeon in the OT. He said कि उसको कल देख लेते हैं, परसों देख लेते हैं, अभी ऐसी क्या जल्दी है, सर्जरी तो खत्म हो गई. And that I became thiazical. because whatever this xylocaine, bupivacaine, and the toxins are there, they cause too much of damage to the intraocular tissues, and you cannot retrieve those eyes. Immediate vitrectomy is the only answer. And so this was removed from here. And lasered the break area. And this patient had a very tight orbit. And in fact, the assistant was feeling a little reluctant to give the block. She wanted to call me, but by that time I had gone for washing up, so she thought that she'll go ahead. And this is it. And these are so toxic. I mean, immediately after surgery, the patient had very good vision, but the story never ended actually. I'm not going further. And what happened, the next time patient had so much of a fibrosis, in spite of immediate vitrectomy, we had to do the second retinal surgery. And then again, third time he had a detachment, we had to do the retinal surgery thrice for this patient. Only then we could, retina will keep on getting fibrous every time over there. And so, I mean, if we do not done vitrectomy, you can imagine how much fibrosis happens over there. So whenever there is a globe perforation, I think we should go ahead and do the vitrectomy immediately. Now you want to discuss, I should go to the second presentation.
Dr. Shroff, you want to add something?
Yes, sir. Sir, could you foresee the perforation, scleral perforation before inject? It was the under peribulbar anesthesia.
Yeah.
And your anesthetist has given the peribulbar, sir?
No, my mother, senior resident.
Okay, fine. But was there any prediction you could have, you could have predicted?
Yeah. This
High
then we
myopia
realized
or
the orbit was very tight, the globe was large, patient was little, and actually this I was feeling guilty. There was no need to actually give block in this patient.
Yeah.
But I thought because as I'm telling you, this will have a very good case for recording.
Yeah.
So I asked them to give the block so that the patient is quiet, I can do my recording very nicely. So that was the reason.
But it has been managed very well. But could you get vitreal surgeon, VR surgeon at that point? Was it
No,
present?
we have got, in our unit, the VR surgeon is
Very
always
good,
there.
sir.
So
Very good.
So there's
Good.
no question. At my own setup, I'm there.
Sir,
also.
what was the post-operative visual recovery?
Immediate visual recovery was 6.9. After second surgery and third surgery, it came down to 6.18. Okay. Patient had 3 times VR surgery actually.
Oh.
Every time we had to fibrosis, then we did the retinotomies, then lasered around that area, so it will keep on getting fibrous at various places, it will keep on crumbling, then go inside. Vitreous was already removed. It was shrinking, so we cut the retina, do the retinotomy and laser around it, and then go ahead. So ultimately we could say.
Sir, it reminds me one case, just 1 minute. It reminds me one case where it had happened. It was a very small perforation, and fortunately the bleeding which occurred, it closed that perforation. I didn't do anything, and the blood absorbed of its own, and the vision was very good. Because we didn't interfere with the vitreous.
If there is nothing
but then
else,
you have to take chance.
Yeah. I mean, you were lucky. Actually, I was the very early surgeon, as you know, in doing converting to the topical. My junior, the co-author of my book, Dr. Anita Sethi, was assisting me, and I was operating. I was talking to her. I never had perforation in my life, but somehow or the other, I'm scared of giving a block. I mean, this is one thing which I don't like happening. And at that time, when I'm talking to her, I'm operating a patient, and that patient was not cooperating. So she was moving around. I said, "Lao, acha block lagate hain." And I gave the block, had a perforation there. I mean, just talking on the table, and the patient had a first perforation of my life. Sitting and talking to her, I never had a perforation, but still I'm so scared. And then I called the VR surgeon for the first time. Luckily, I had operated her other eye under topical, so she could not blame me. I mean, she was not cooperating. But
what are you feel that other signs is only the hardening? What are the other signs of suspecting the globe perforation?
I think either the eyes becomes too hard or too soft. I mean, most of the time it becomes too soft because you suddenly withdraw and something leaks over there. But if your needle is fine, 26 volt
many
needle,
time
it
your
will become too
red
hard.
glow disappear
Red glow disappears.
because of the hemorrhage, whatever the clear red glow.
So if the blood is there, then you can see when you are looking at the operating microscope, some shaking things over there. But when you're doing that.
Okay, you can go to your next video showing.
I
Zeptorexis.
think we all have the femto going great, but now we have got another very good option, what we call as a Jepto, and I think this is a fantastic tool. And at many places where your even femto will not work, but this will work very well. Now this patient actually had more than 36, 38 RK cuts, was NRI, came to India and was more worried, had high myopia, had a very poor vision, more worried about the white opacity shining through all the time and had a squint. So wanted to go for a squint surgery for cosmetic reasons and wanted to this white opaque removed. So you can see that in these cases, the Jeptorexis can be done very well. And after doing the Jeptorexis, people become small and we put the Malvin ring afterwards. And the Jepto has got an advantage that even in spite of being the fibrous capsule underneath, but the capsule is cut on top of it. It is a fibrous block which is underneath this. So we removed this fibrous by seizure, and once we place the lens inside, and then because his basic concern was cosmesis, so we thought given this might come into the center, so we removed the remaining fibrous block as well. So the Jepto can be performed even in a small people, that is the unwardness. And this is the another very interesting case. Patient had a cerebral ataxia, had a lot of problems, and she had a bilateral mature cataract, and the GA people refused to give the GA to her, and she was really virtually blind, and the whole of the family was very stressed, and she will keep on shaking like this. So the Rexis is the key to operating these cases. So Jepto again helps in such cases when the patient is actually, you can see the amount of shake the patient has got. Now, so this is the type of situation, but the Jepto will still work in these cases, and rest of the, because when you are doing phacoemulsification, you can still hold on with the phaco probe and the second instrument which is holding on the side, you can ask the assistant to hold with the forceps. But while doing Rexis, you need to have a good control. And if the Rexis is not there, you will find it very, very difficult. So Jepto is definitely a new tool and can help us in many situations. And I think most of you are doing Jepto, so you will like to comment something.
We are not doing Zepto, but
not
definitely it is a good and cheap alternative to femto. But where there are some few problem with the Zepto.
Yeah.
It is slightly bulky, and because of the heat radiation, sometime in subluxated where the zonules are, because it works by fibrosing by burning this. So there is a shrinkage of the capsule. So it gives slightly more stress on the zonules, and if you move and if it is not subject, you can slightly dislodgement of the nucleus maybe there is, especially in subluxated.
No, it is not the shrinkage of the capsule which causes pressure, but of course the suction which you produce over there may cause pressure on the zonules in a subluxated cataract. And this instrument
For
definitely...
that, femto will be more ideal than, definitely too costly, but then femto will be more ideal than...
Yeah. So there will be always a case for the femto, there will be always a case for a Jepto. Like in those two cases I have shown, femto will not work and neither the manual will work so well. So these were two cases where the Jepto was excellent. Jepto needs a little more refinement, there is no doubt about it. There are certain problems in this sense because the neck is very weak and the centration at times is difficult.
Okay.
There are only one size available, 5.2 millimeter, while many cases I prefer to have 4.8 or 4.9, because even if there is a slight decentration, still the Rexis margin is well covered. The silicone tubing is little larger than the ring, so at times if you are not careful, you can hold on to the iris over there. And the reflex action which is there, which creates the hydrosection also, should be more gentler, or a vacuum release system should be much finer. So the Jepto needs some refinements, but at the same time, it is an excellent tool and really works very well and very economical. and costing 9-10 lakhs rupees, hardly any investment.
Okay,
And
Harbans,
can in certain
you
situations
can
help.
you can shift to the another case because now it's only 5 minutes left. So please,
So I'll go into the,
your last case.
no, I have this, that.
Meanwhile, Rajiv, would you recommend strongly, if you are excellent surgeon?
No, this was
would
a
you-
patient.
Would you
just-
recommend
Just 1 minute.
regular axis? on this
Dr.
abdomen?
Sharaf,
Please.
just watch this video. So this was a patient where we had planned for the toric IOL.
Video is not coming.
Are आ गया?
Yeah, yeah.
So this was the patient when we are about to remove the last fragment. You can see we had a PCR over there. So now the patient had a high astigmatism, and as we know that in the presence of a PCR there are high chances of decentration. Now before withdrawing the probe, I am injecting the viscoelastic so that the vitreous does not come into the Philsop hole of the anterior chamber. And then we use the vitrectomy cutter for the cortical aspiration. And we know that the putting in a toric IOL, whether to go for a toric IOL or not, will be debatable in such cases, because we know that in presence of the PCR there are high chances of decentration taking place. But this patient had around 5 diopter of astigmatism, so we thought we'll go ahead and put the toric IOL. If need be, we'll explant it instead of putting the pressure to the laser machine. There's another option that you put on a monofocal IOL and then do the LASIK laser afterwards, after 3 months. So now look at this. I place the lens into the AC. I do not dial into the bag, and then I just pull the loop, and in desired axis I guide it into the rhexis, because in presence of the vitreous I don't want to rotate the lens. I put the lens into the chamber on front of the iris and pull the loop and guide it into the bag. Both the sides, you might have to use the 2 instruments. And now after putting the lens, I stain with the tricot, which is diluted 1:4, and then do the vitrectomy. So if there is no vitreous in the AC, and if your lens is in the bag, actually it will remain centered. It is only if the vitreous tag is there attached to the lens or coming to the wound, it may have a problem. So the patient luckily had an excellent outcome. Thank you for your kind attentions.
Why not in this type of cases put the monofocal in,
Yeah, I
later
agree
on
with
do the toric correction by the laser?
Yeah, yeah. I
That
think
will be probably more precise than, because
many a times I do debate in my mind whether actually we need to put in a toric IOL at all. I mean, if you see the
Because,
cost of the toric IOL, in any case we charge 20,000, nearly more than what we charge for the monofocal IOL. So with that cost, you can always do the laser, whatever is the residual refractive error afterwards, whether it's a 2 diopter, 3 diopter, cylindrical, spherical, everything you can correct. But of course, patient will not like to go under the blade, under the surgery twice. So patient prefer that everything should be finished in one go. And the lasers, now you are subjecting a patient to the double the rate of complication. And the chances of dry eye and those discomfort may be higher. So if in the single surgery things can be finished off, that would be better than subjecting the patient to the 2 surgeries.
okay, thank you, we are finished, we are just finished in time. Thank you my all is Dr. Harbans, Dr. Shroff, Dr. Rajesh Joshi, Dr. Maipal, Dr. Chitra and all of you. Thanks for joining us. Now the next session. Kiska?
Chalo ji.